I don't think I need to press anything in particular for our attendees to see us. I have no idea. It's my first webinar, as I said. They may be watching me right now saying, nope, you don't need to press anything. I've been watching you chat for 10 minutes.
Yeah, I mean, if you do have their, yes, they are, right, yes. We got something in chat.
Oh, yes, we are. Nice. Thanks, Mark. Let's see. All right. Well, then let's get started. Bring up my introduction here. All right. So welcome, everyone. My name is Dr. John Miner, and I'm an associate professor of theology here at Franciscan Missionaries of Our Lady University. I'm delighted to welcome you to the Franciscan Missionaries of Our Lady University's Bioethics lecture series. This is actually our 8th lecture, which means it would have been on for 4 years, but we had a bit of a blip for a while because I was resistant to doing online webinars. So I canceled for a whole year. But here we are because I attended a few and I thought, actually, this isn't bad. This is kind of nice. So I decided to try one of ours. Hopefully in the fall, we'll be back in person, but all of our previous lectures are available on our YouTube page. Well, some of them. I actually lost some of the videos because previously I'd have to get a video camera and like set it up and then find the video back and upload it on, I don't know. All this seems archaic now, but that was 2 years ago. So you can find some of our lectures there, our previous lectures. So the purpose of the OLOL or the FMOLU Bioethics lecture series is twofold. So first, it aims to increase knowledge and awareness of bioethical issues among students, faculty, and medical professionals in our kind of wider community here in South Louisiana. And second, it aims to approach these issues from within the Catholic tradition, kind of applying its perennial wisdom to the kind of contingencies of today. So if you'd like to keep up with the lecture series, feel free to type your email into the chat function and ask to be signed up. I'll do it typically in person. You could sign up on a sheet, but I don't have a sheet and I'm not as fancy enough to like make it appear on the screen and point to it or something like that. So if you want to send me your email and say, sign me up, I send probably 2 emails a year. That's it, if that's important to you. That's the kind of thing that's important to me. I unsubscribe from lots of things because they send too many emails. Anyway. So if you do sign up or you're already signed up, keep an eye out for the fall. We have Dr. Charlie Camosi coming to speak on a throwaway culture in medicine and how we combat that. And then also his second lecture will be on the moral status and use of animals in biomedical research, something that's near and dear to his heart. So look for an email concerning his lecture in the fall, which will probably be in person. So tonight we've got a real treat, and I'm very happy to announce or introduce Dr. Paul Scherz. Just by way of introduction, I will read you a few of his accomplishments. So Dr. Paul Scherz is an associate professor of moral theology and ethics at Catholic University of America, where his teaching and research focuses on bioethics. He's also the co-chair of the Catholic Clinical Ethics Joint MA program with the Pellegrino Center at Georgetown Medical School. Dr. Scherz's research interests draw on his dual trainings in theology and molecular biology. He received a PhD in genetics from Harvard and a Helen Hay Whitney postdoctoral fellowship to work at UCSF. But after doing that and growing more interested in the ethical and theological issues arising from his scientific research, he went back to school and got a PhD in moral theology from the University of Notre Dame. His research examines the interrelationship between theology, science, and medicine. With a recent book, Science and Christian Ethics. He has a more recent book since I wrote this, an edited volume on end-of-life care. But in his recent book, he examines a lot of this in Science and Christian Ethics, investigating contemporary moral formation in science. He's also published on end-of-ethics the ethics of end-of-life care, as I said, transhumanism, AI, data ethics, and emerging genetic technologies. So Dr. Scherz will present for about, I don't know, 40, 45 minutes. And then we'll have about 15 minutes for questions. So feel free while he's talking to type your questions into the question box and throughout the lecture. And I will keep tabs on them and then present them to Dr. Scherz during the question period. So without further ado, Dr. Paul Scherz.
Okay, thank you for that introduction, and thank you all for joining us over Zoom tonight. I'm going to share this, my PowerPoint here, so you all can see this. So tonight I'm going to be talking about Catholic social teaching and healthcare ethics. So there's been an increasing recognition over the last 20 to 25 years that social factors seriously affect issues of health and illness. The pandemic has made that starkly clear. You need only look at the racial disparities in COVID mortality. According to CDC data, African Americans are 1.9 times more likely than average to die of COVID. Hispanic or Latino Americans are 2.3 times more likely. Native Americans are 2.4 times more likely to die. And these aren't due to genetic differences or anything like that. They're due to social factors stemming from this long history of racial injustice and various kinds of social injustice. So what would those be? So we can think of poverty as a cause of many of the comorbidities which we know leads to increased risk of COVID death, right? So we know that diabetes, heart disease, these kinds of things are occur more likely among low-income populations. A lot of this is due to factors like living in a food desert where there is not access to grocery stores from where you can buy good quality food. Some of it is from stress due to precarious employment, these kinds of social issues. There's also issues of housing. We know that the virus spreads most easily within households and especially easily through multi-generational households that live in confined living quarters. So therefore, for those like these groups, like groups in poverty who are less likely to be able to afford different kinds of housing and who are more likely to live in multi-generational housing, that puts them at greater risk. And the service jobs that are done more likely by those who are at a lower income level, they're less easily done remotely. So there's difficulty in social isolation, right? So because of the role that social organization, social factors play in illness and disease, we've recognized that healthcare ethics itself cannot remain confined to the clinic if it wants to address these kinds of broader issues. Even in the clinic, issues like where are you releasing, in the hospital, where you're releasing a patient to, like, do they have housing? Are they going to be able to afford the food and medication they need? These become very important issues. Right. So there's a recognition that we need a social ethics as well as the clinical ethics that we have such a rich tradition of in the Catholic Church. Luckily, the Church also has a very rich tradition of Catholic social teaching, which is traditionally thought to start with Leo XIII's release of the encyclical Rerum Novarum in 1891. In this encyclical, the Pope was responding to a number of issues that arose over the 19th century. So industrialization was causing massive social dislocation at the time. People were driven off farms into cities. They had their networks of solidarity were broken up. And a lot of them fell into poverty or into very difficult working conditions in the factories of the time. And this was leading to social unrest, but also the demoralization of the working class. The Church was also facing new philosophies about society. On the one hand, an individualistic liberalism that sought to govern everything by contract and by the market, with very little role for government or very little duties to care for others. And the other hand, there was socialism, which sought to try to suck all social roles and responsibilities into the government, into the state, and therefore leaving very little liberty towards the individual. Both of these views didn't take into account the full richness of the Catholic understanding of the person. So the church was seeking to find the truth amid these extreme views. On the one hand, yes, that we are made for community, but on the other hand, that we also need to recognize individual dignity. And so it developed this set of doctrinal principles over the last 130 years in a series of social encyclicals, and also letters from bishops, documents from bishops' conferences. So it took about 40 years between the first and the second what are recognized as social encyclicals between 1891 and 1931. But since then, they have come more frequently, every 10 years, even more frequently than that. The last document in this social tradition was released just in September, Pope Francis's encyclical Fratelli Tutti, which focuses on the issue of solidarity. So there's a number of documents, but these can be brought together into an understanding of what the church teaches on social, economic, environmental, and political issues. And probably the best kind of synthesis of this is in the Compendium of the Social Doctrine of the Church, which was released by the Pontifical Council for Justice and Peace. Now, this is a very rich and there's a lot of meat to this tradition, so I'm not going to deal with everything tonight, but I do want to talk about some aspects, some principles in the tradition and how they apply to healthcare, because this is becoming an increasing focus in Catholic healthcare ethics, as we've discussed. As any of you who are familiar with the ethical and religious directives which govern healthcare institutions that are released by the US bishops, they have a very rich teaching on traditional kinds of topics like beginning of life ethics, end of life ethics. How do we talk about ordinary and extraordinary care and treatment? But there is less on these kinds of broader social issues. So moral theology today is seeing a need to draw in this social tradition into the understanding of Catholic healthcare ethics. Now, before we dive into the heart of my presentation, I want to prevent one misunderstanding. Sometimes in society, you'll see people talking about an opposition between people concerned with social justice and people concerned with life issues. Now, in terms of Catholic moral theology, that's a false dichotomy. As we'll see, both the concern for protecting human life and the concern for social justice and social justice arise from the same source. And that is what's called theological anthropology, or that means the understanding of the human person. So as the Compendium of the Social Doctrine of the Church summarizes, the object of the church's social doctrine is essentially the same that constitutes the reason for its existence. The human person called to salvation and as such entrusted by Christ to the church's care and responsibility. So the focus is always on the human person who has an eternal destiny, but also the church is called to support the flourishing in this life by supporting teachings that will lead to a just society. So what is this understanding of the human person? Well, you can summarize it very simply in two words: the imago Dei, or the Latin for the image of God. The church's theological anthropology is founded on this understanding found in the first chapter of Genesis, that we were created in the image of God. So God created mankind in his own image. In the image of God, he created them. So simple at one level, but once you try to understand what does it mean to be in the imago Dei, it gets much more complicated. And tonight I want to talk about different aspects of being made in the image of God and how they have led to principles of Catholic social teaching, right? And how these principles in turn can be applied in the healthcare setting. So I'm going to talk about four aspects of theological anthropology: that humans have dignity and sanctity of life, that we are made for community, that we also have a duty of stewardship, caring for things as the way God would want us to care for, and that means caring for ourselves, others, and the environment. and that we possess reason and free will. And these lead to a number of principles, such as principles of human rights, principles for preferential option for the poor, an understanding and duty towards the common good, understandings of property, the dignity of work, and care for the environment, as well as a focus on how we organize society in order to support everyone's participation. So in each section, I'm going to start off, and this is, in some ways, this is somewhat of a useful kind of gathering of these many principles of Catholic social teaching. I'm not going through all of Catholic social teaching, but some major points and looking at how they apply to healthcare ethics. Okay, so let's start out with the Imago Dei and dignity. So basically, we are made in the image of God, and thus we reflect in some way this. We are very important. We're important creatures in this creation, and that means our life is sacred. It is this dignity that leads to the sanctity of life, and we see this affirmed in later on in Genesis, just a couple of chapters later, after the flood, when Noah makes a new covenant with God. One of the rules that God gives is that whoever sheds human blood, by human shall their blood be shed. For in the image of God has God made mankind. Okay? Because we exist in the image of God, our lives are sacred. Right? We have a sanctity of life. This leads to, I want to say, well, the two things are tied into this sanctity of life. Rights, tied into this rights to life, rights to the things that we need for life, but also a preferential option for the poor. Okay. So the sanctity of life obviously leads to the right to life. Here you can see the March for Life, right? So we are, because of the sanctity of life, humans can't be directly killed. But not only does it mean that humans can't be killed, it also means that we have a set of rights for the things that are necessary to maintain that life. And these were put forward, really, these sets of rights in John the 23rd's encyclical Pacem in Terris in 1963. So because man has a right to live, he also has the right to bodily integrity and to the means necessary for the proper development of life. These include things like food, clothing, but he says medical care. There's a right to medical care. In consequence, he has the right to be looked after in the event of ill health, disability, widowhood, old age, or whenever through no fault of his own, he is deprived of the means of livelihood. So because we have a right to health, a right to life, we have a right to the things that maintain our life, right? A right to be cared for, medical care. Now, it's important to understand how this differs from other ideas of rights around health, right? This is a right to health care. Now, we can talk about it in distinction from the World Health Organization, which also defines a right around health. So it says that defines health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And it says that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, or social condition, right? So in the Constitution of the WHO, there's put forward a right to health and to the highest attainable standard of health. Now, many philosophers and theologians, and many Catholics among them, this definition of what we understand the rights of healthcare are is very problematic, because it leaves out of the picture that we are destined to die, to have health crises, perhaps suffer from disability. We have other goods in societies that we are seeking after. And so it's not a right to health, not a right to actually possess this highest attainable standard. It is actually a right of access to a reasonable standard of healthcare. Healthcare is never going to get rid of suffering, and it can't promise a right to that, but it can give us an access to care. Now, what that means, this right, it will differ according to what society they live in, what stage of history. There's also, the church doesn't, when I'll talk about more about this, talk about particular policies or arrangements of the healthcare system. But it does say that every society must have an access to a reasonable standard of healthcare for that society. Okay. This also turns around to a need to care especially for the poor in society. If we're going to act for the dignity of each person, you have to pay special attention to the poor, because the poor are those who, and the disadvantaged are those who are most likely to have their dignity ignored. And we see great biblical evidence for this special care for the poor. The prophets in the Old Testament denounced the elites in Israel for their oppression of the poor. If we look to the picture of the Last Judgment we find in Matthew, Jesus separates the sheep and the goats, saying, "Amen, I say to you, whatever you did for one of the least brothers of mine, you did for me," saying that we need also to care for those who are poorest. And this is called the preferential option for the poor, a term that emerged in liberation theology, but was rapidly adopted into broader Catholic social teaching by Pope Paul VI in his letter Octogesima Adveniens, when he says, "In teaching us charity, the gospel instructs us in the preferential respect due to the poor and the special situation they have in society. The more fortunate should renounce some of their rights so as to place their goods more generously at the service of others." Now, this doesn't mean that the poor are better in some way, but what it says is that the poor are more likely to be harmed by social systems. They're more likely to be ignored by people in society. So if we truly want to see whether we live in a just society, we should pay special attention to how our systems of power, our systems of society treat the poor. Okay? So that means that Catholic healthcare has a special vocation to serve the marginalized and disadvantaged through programs, charitable care, and other ministries, which is a ministry the Catholic healthcare has carried on since its very origins. So who would this be? This would be those who are suffering material poverty, but those who are disadvantaged in other ways, minorities, immigrants, those suffering from stigmatized conditions, addicts, mentally ill, the elderly, and those with stigmatized diseases like HIV or Ebola. Right? These need to be a special source of concern. Today, we see this concern for preferential option for the poor, I think most especially in the discussions around vaccine. If you look at Pope Francis's Christmas message, his Urbi et Orbi message, he said, "I ask everyone to seek a solution for the pandemic for everyone. Vaccines for all, especially for the most vulnerable and needy of all regions of the planet. Before all others, the most vulnerable and needy." And there's been in many other documents written by church leaders and moral theologians about this problem, that it's really the wealthier countries in North America and in Europe and East Asia who are buying out the vast bulk of vaccines at the time, leaving little for the many thousands, hundreds of thousands of people who are becoming ill in countries like Brazil and Mexico, Tanzania. Right? They're not going to be made available. And what the church is calling us is that we should see how can we distribute these resources better to make sure we're caring for the poorest among us. And we also see that in our own society, the need to make sure that vaccine distribution is occurring for minorities, for the poor, that we set the systems in place, because it's much easier for people with more resources to get on the website all the time and sign up, find the place that has the vaccine and make the time for that. Okay, so that's human dignity. It leads to our rights. It leads to a need for caring for the poor, for the dignity of all. The second aspect of the Imago Dei is sociality. And if we go back to that first verse, that verse that I talked about at the beginning, God created mankind in his own image. In the image of God, he created them. You get a sense of this in the end. Male and female, he created them. We are already created multiple, and in this community, the community of the family, which is the basic cell of society in Catholic social teaching. So we're already created in a relationship of male and female. But we're also imaging not just a God who is the one God, well, God is one, but he is also the triune God. And the Compendium says, to be human means to be called to interpersonal communion, because the image and the likeness of the Trinitarian God, the Father, the Son, the Holy Spirit, who exist in this relationship of love, are the basis of the whole human ethos, which reaches its apex in the commandment of love. Right? So we're this Trinitarian call, this creating a relationship of male and female. But even in classical philosophy, in Aristotle and the Stoics, there was a recognition that humans were social animals, that Of course, someone could live off on their own in the woods as a survivalist and probably get by. But if you actually want a flourishing life, you need to live in a society. And if you want to have children to be raised well, you need a society, you need others. Right? So this idea that we have an end, that we are to live together, means that we also have a common good. There's a common end that we all share. Right? So what is this common good? The common good is a complex and disputed issue, I would say. But the way that I understand it is that all social groups have certain things that they're aiming at, right? So families are aiming at raising children, supporting each other. Corporations are hopefully aiming at producing a product, not just making money, but producing a product which serves others. They're working together to do this. There's this common aim. Non-governmental organizations, nonprofit organizations have an end they're seeking. Healthcare is trying to support health among its patient communities. Now, these ends are shared by all of the individuals in the group. Hopefully, people are working together to achieve these ends. And it's not just that we work together to achieve this external good, but it's in part by working together and achieving this good that we're supporting our own flourishing. Now, if you'll see that there's different shapes of the common good occur at different social groups. There's a common good that a family has, a corporation has, but there's also a common good of society. I'll talk more about that in a moment, a kind of creating the conditions of life for flourishing of people in society. There's Thomas Aquinas has taught that there was a common good for the universe, which was to give glory to God. And there's a common end of the church, which we saw is to bring people to eternal life and serve as the body of Christ. Now, it's important to note that this common good is neither individualist nor totalitarian. Right? So on the one hand, common good must serve the flourishing of the individual. We're not talking about a utilitarian thing which people can be sacrificed for the good of society. You must always respect human dignity. You must always respect individual rights. Yet, it's not individualist in that the individual realizes their flourishing through the service of the common good. We realize our flourishing by helping others, by self-gift, by being a good nurse, a good doctor in a hospital. We realize our vocation, our own good. So the common good is both serves the individual, but also the individual is fulfilled by serving others. Okay, now, as I said, I'm going to go into what is this, the common good of society. Gaudium et Spes, in perhaps the not clearest definition, says that the sum of those conditions of social life which allow social groups and their individual members relatively thorough and ready access to their own fulfillment. So it's conditions of social life. And there's multiple kinds of things we need in order to seek our fulfillment. We, of course, need the social systems to meet our basic physical needs. We have to make sure that people have shelter, people have food to survive, that people have the healthcare they need to be taken care of in times of illness. Right? So these basic rights need to be taken care of. But also we need a social situation that can support our social needs. We need a society which supports our friendship with one another, our participation in that society itself, and our freedom of action. Right? So we need to create a society that supports those things. But we also need, as part of the common good, to support people seeking higher ends. Everyone is served, both individually and collectively, by increasing virtue in society. We have to have a society that supports us in seeking our spirituality, in seeking God through religion and the freedom of religion. So you need these basic conditions at these different levels to be met for it to be the common good. Now, that's the good thing, good side of things, and we're working together. But because we are social, also our evil actions, our sinful actions also spread to others and contribute to the problems in society. We're affected not only by good things of others, but also by their sins. Pope Francis put this: just as goodness tends to spread, the toleration of evil, which is injustice, tends to expand its baneful influence and to undermine any social system, no matter how solid it may appear. It is evil, crystallized, and unjust social structures which cannot be the basis of hope for a better future. So since John Paul II, we've called this crystallized evil, the way that social systems can lead to sin and be and injustice can be furthered by sin. We've called this structures of sin. And the way that you would translate these structures of sin would be into social systems that lead to the problematic social determinants of health. Now, as I said at the beginning, we know that a lot of things that health isn't affected only by clinical care, but also by all the structures in society. And these have been called the social determinants of health. So what are these? So we can think of housing, right? If people don't have access to housing or overcrowded housing, this can lead to disease, the spread of COVID. It can lead to homelessness, where also you're seeing spread of homeless in places like Los Angeles. And there's also many other health problems that come from homelessness, the inability to maintain continuity of care, exposure. There's also problems in access to food. There's food deserts, right, where people can't access grocery stores, that they have to buy food at gas stations where they can't get vegetables, or that they don't have that access, which can lead to obesity and to various other illnesses tied to obesity. There's also the fact that our food system tends to subsidize unhealthy foods. There's employment, right? Precarious employment, having to work many, many jobs because you can't get a living wage off of one, can lead to stress, heart disease. And there's also racism, which generally racial injustice has led to these other kinds of problems of poverty, housing, employment, but also even just on its own, it seems that exposure to racism can lead to low birth weight, which we see amongst African-American populations. And that hasn't been able to be explained either by inherent genetic factors or by these other social factors. It seems to arise from racism itself. Right? So healthcare providers and organizations need to be cognizant of this wider context if they're going to serve people well. So how can healthcare engage with this? Well, we know that religious organizations intervened wherever help was needed. So if we go back to the religious sisters who founded Catholic healthcare, which for a large part, they not only founded hospitals, they were also working on schools, on orphanages, on poor relief, anything that the community needed, anything what they saw was lacking in their communities, they sought to address that. Even today, we see that healthcare organizations are also acting to address social conditions and thus attain broader common goods. As nonprofits, they provide charity care, but they also provide community benefit programs, which can lead to benefits in the communities around the healthcare systems. They engage in lobbying, not only on healthcare issues, but they can also lobby about, as their major voice that can lend their weight to other issues at a local, a state, a federal level. They can also make partnerships with other organizations. I know many healthcare systems partner with anti-trafficking organizations, anti-human trafficking organizations. Many partner with Mercy Housing, things to do housing development, many other things that they can work together to address these broader needs. Tomorrow in my talk in the morning, I'll be addressing some of the problems that can arise and how to do that and ways that one can do that well. But just in general, there is this important aspect of turning to these broader issues, even if you just want to affect the diabetes that you're seeing in your patient or the heart disease. Okay, so we've gone through dignity and the social nature of humanity. Now we'll go to the third, which is dominion, this idea that humans have dominion. And this leads to the verse right before the one I quoted at the front, where when God's deciding about making mankind in his image, has let us do it so that they may rule over the fish in the sea and the birds in the sky, over the livestock and all the wild animals, and over all the creatures that move along the ground. So humans were supposed to have this exalted position, taking responsibility for the rest of creation in a certain way. Now there's been modification. So this was originally termed dominion, but because of how this is translated in Latin, but that has some connotations of property, of control. Masters have dominion over slaves. And so it has been translated in some parts of Christian history. People have thought about this as we have total control to do whatever we like with the rest of creation. People have accused the Catholic tradition of having this view, but that's not so much, not as accurate, historians say. But because of this concern with dominion, which can come even into the healthcare setting, where we can think of autonomy, where people think they have total autonomy, total ownership of their own body, that they can, sell organs, that they can commit suicide, right? That they, through assisted suicide, they have control over what to do with the body. Catholic teaching has taught that no, instead we have stewardship. As John Paul II put it in Evangelium Vitae, man's life comes from God. God, therefore, is the sole Lord of this life. God has true dominion. Man cannot do with it as he wills. What we are called to do is take responsibility for our lives, for society, and as we'll see, for the environment, to work God's will in the world through caring and through loving, right? So this dominion, we can see this in Catholic teaching on property. So as I said at the beginning, one of the major impetuses was the growth of socialism, which sought to take all private property. So Leo XIII, in that first encyclical, affirmed that humans have a right to property. Every man has by nature the right to possess property as his own. Why is that? Well, that's because that allows people to exercise their freedom, to exercise their stewardship, to use their prudence in order to serve others. Right? That we have this duty to use our gifts. And there's also the problem that people are going to take better care of things that are their own than things that are common. There's the classic tragedy of the commons, in which common property can frequently be degraded more rapidly. Okay, so we have this right to possess property that we can use for the good of others. But it's important that that this right is not absolute, right? Christian tradition has never upheld this right as absolute and untouchable, says John Paul II in Laborem Exercens, written 90 years later. On the contrary, the church has always understood this right within the broader context of the right common to all to use the goods of the whole of creation. Dominion is granted to humankind as a whole. So the right to private property, it has to be subordinate to this right to common use, to the fact that goods are meant for everyone. Okay, how do we balance these things? Well, it means that our property rights are limited in such that our property can be taxed and used for social programs that serve the common good, such as healthcare. Also means that individuals should donate excess of their income to aid the common good, especially in regard to the needs of the poor. So we have this right to property, but also this need to use the surplus to serve others, and the right that the society has to use a reasonable amount to care for common needs. All right. So as I said, there was this concern that people, especially amongst environmentalists, that people were using this biblical idea of dominion to also to destroy the environment and use the environment as just kind of a resource that they can own. Pope Francis in Laudato Si addressed these questions of our relationship to the environment. And he does it by going back to these basic biblical texts on what does it mean to steward the world, to have dominion over a world. And he traces it to Genesis 2, the chapter after the call, the creation in the image of God. The biblical text tells us to till and keep the garden of the world. Tilling refers to cultivating, plowing, or working, while keeping means caring, protecting, overseeing, and preserving. So there's a relationship of mutual responsibility between human beings and nature. We can take from the earth what we need for subsistence, but each community also has the duty to protect the earth and to ensure its fruitfulness for coming generation. The earth is the Lord's, right? This comes from this duty of stewardship. Now, something that's been receiving a lot of important kinds of attention recently has been this relationship between healthcare and the environment. Because people have realized that healthcare can have a large environmental footprint. Think of the plastics used in the hospital, the single-use, various single-use articles, all the plastic wrapping that surrounds almost everything, right? It's a huge amount of plastics that's contributing to pollution and waste problems. Hospitals are tremendous users of energy. And healthcare systems also use a lot of chemicals which have detrimental environmental effects, as we'll see in a moment. So this suggests that healthcare systems should take steps to mitigate harmful effects on the environment by finding things like investing in renewable energy sources for their operations. It's hard to think about like keeping things sterile without having all that packaging and things, although people are thinking through, but even a simple thing is water bottle refilling stations. So you're not having people throwing away plastic water bottles. And another aspect that people could do is shifting usage patterns away from damaging chemicals, medicines, plastics to other kinds of things. Right? What's an example? Well, anesthesiologists have taken this step, including some in Providence Health System. There are two anesthetics, desflurane and sevoflurane, which from my understanding are basically clinical similar in most situations. But one, desflurane, remains in the atmosphere for 10 years, damaging ozone and contributing to climate change, where sevoflurane has some bad effects, but it stays in the atmosphere for just about a year, right? So desflurane has 26 times the global warming potential of sevoflurane. So what a number of anesthesiologists have argued is, and they've tried to educate their colleagues about this, saying, look, if it's basically the same in this clinical situation, why not use the less damaging one, right? So this leads to a way in which just through education, you can shift usage patterns in ways that don't affect clinical care in order to also help the environment. The last aspect of this dominion, the stewardship, is also this dignity of work. As John Paul II says, the biblical calling to subdue the earth, in which is expressed the will of the Creator, that work enable man to achieve that dominion in the visible world that is proper to him. And in that, he's calling out to this point made in Rerum Novarum that workers have rights, a right to a dignified work environment, a right to a just wage for their work, a right to organize in order to defend their rights. There's a need to respect the dignity of the worker. Okay. So what does that mean in a healthcare context? Well, this is in the Ethical and Religious Directive, that you need to have just wages for support staff. There needs to be openness to unionization. When outsourcing, it needs to be done, which many groups do, it needs to be done in a way that you're not just throwing off costs and not caring what the wages of those who are out, that gets outsourced to, what happens with that. But you need to make sure that those workers who are taking over the outsourced tasks are actually being paid and treated well. And even question, when is outsourcing necessary? And finally, there needs to be a focus on conditions that can lead to staff burnout and moral distress, because these help to undermine this dignity of work that's tied to our call to have dominion over the earth. Okay, the last point. We have, part of the image of God is that we have reason and free will, because we believe that God is rational as well as loving, but that God is free, and he uses that to achieve good. Right? So this is what John Paul II says, but this is a long tradition that the ability to attain truth and freedom are human prerogatives, inasmuch as man is created in the image of his creator, God, who is true and just. This idea of the Imago Dei being tied to capacities to be reasonable and to have free will to act go a long way back to Thomas Aquinas, before him to Augustine, to the Eastern Church Fathers, even back to the very early church. The focus on free will was very important. Right? So what does that mean? Well, that means that we should have free action. And as we said about with property, the opportunity to participate in seeking the common good. Gaudium et Spes says that God has willed that man remain under the control of his own decisions so that he can seek his creator spontaneously and come to utter and blissful perfection through loyalty to him. We should not use our freedom selfishly, but to seek God. And it's we can only come to love God. Love is a free action, right? So freedom is necessary. So we need to use our reason and free will to serve God and the common good. Now, one aspect that's tied to this is this idea of how should we organize society? And this is the famous principle of subsidiarity. And Pius XI, who was Pope in 1931, was living at a time in which totalitarian states like fascism, like Stalinist Russia, like the emerging Nazi threat in Germany, were kind of bringing all things into the control of the state, down to the last detail of society. That's why they're called totalitarian. And he said that in itself is unjust, because you should not assign to this larger level of society what lesser and subordinate organizations can do. Why is that? Because people need a chance to participate, right? As much as we can do at this lower level, we should allow people to be on local school boards rather than having all these decisions be made at the federal government. That decision should be made on the local healthcare team even, rather than at higher levels. We should let subordinate groups handle matters and concerns of lesser importance. Now, this not only is to respect their ability to act freely, but it also is important because people on the ground in position are able to know how to respond to situations frequently better. They have more information. Okay. Now, how does this tie into the medical professional? Well, I'm going to connect it to the growing bureaucratic control that we're seeing in the medical profession now. We know that insurance, both private and government, and healthcare systems are aiming at greater predictive control of their workers. In this sense, autonomy of doctors and healthcare workers, nurses, other professionals are becoming imperiled. How do we see this? All right, I want to use the example of guidelines, how they're translated in metrics in medical practice. Now, treatment guidelines, what are these? Okay, so this is something where somebody comes in, they have a certain blood pressure, right? You're supposed to give them a certain medication. If they have blood sugar over a certain level, you give them a certain medication. If they have certain conditions, the guideline says that you should do a certain surgery, right? Now, the treatment guidelines have exploded, growing from 70 treatment guidelines in 1990 to over 7,500 by 2012. There's some movement to kind of trim these back, but the impetus is for broader growing. Now, it's one thing to know these guidelines, they can be very helpful, but the problem is that these guidelines get translated into quality metrics that are that basically say, are these people following these treatment guidelines? And then these metrics are used to assess performance of practices and individual. And then these performance analysis metrics are then affect reimbursement. If you're found you're not following the rules at the same time, you're following the rules enough, then you might get your pay docked. Now that might sound okay, but there are some things that can emerge that are problematic from this. Let me give you one story that was told by George Sorosi, a surgeon. He tells the story of one of his patients who at 80 had no medications and no abnormalities on physical exam. But he did have high blood pressure, 150/96, and blood glucose of 180. So because of this, he was given medications for both these conditions. Now, the problem was, as time went by, he was given higher and higher in doses, more powerful medications because his numbers were coming down. He was fine, physically, he was fine. He had no visible problems, but his numbers were too high. So they kept ramping up these things. And part of this was because the people in the clinic were being judged on these quality metrics. So because the numbers weren't budging, his numbers weren't budging, they had felt the need that they had to get more intensively involved in pushing those down. Now, he started to have problems needing to go to the bathroom in the middle of the night. He started to become lightheaded when standing as these medications increased in power and dose. leading to at 86, when he fell and broke his hip while getting up to go to the bathroom in the night. They found that his blood pressure was incredibly low, 80 over undetectable, a very low blood sugar as well. So he had to go into a surgery. He ended up having stroke and complications during the surgery to address his hip. And he's unlikely to ever live independently again. And this intensive care exhausted his savings, and he lost his house. As the author says, his doctor may have received a bonus for adhering to the guidelines, but the patient lost his home and his independence, right? So the problem that Catholic social teaching shows us is when too much control goes up and is away from the medical team, the medical professional, the ability to act autonomously using their reason and free will, this can create problems. It hinders the attention to the individual circumstances of the patient, and can cause many cases of overtreatment. Now, this doesn't mean that higher levels of society don't have roles to play. I mean, you do want healthcare systems to be checking out to see if people aren't giving good care at all, right? That is a reasonable thing to do. But there has to be this balance. John 23rd says that government has an important role to play, that the increasing social insurance systems that we see in modern states do allow for the exercise of rights, especially economic and social rights. But governments and all of these hierarchical organizations need to achieve a balance between autonomous and active collaboration of individuals and groups, and the timely coordination and encouragement by the state of these undertakings, right? So where do you need to strike this balance of having things, as much as possible done at the lower level, but also having larger levels, both to support the lower levels through economic support, but also to make sure if injustice is occurring, like you have a racist town, to make sure that those injustices get sorted out. And so you can think of issues like expansion of healthcare. That's something that needs all levels of society working together. Medicaid policy is federal, but also state, also local. In healthcare, you can think of mergers. We all know that Catholic systems are getting larger and larger. And there's a question as to, okay, how do we ensure that that individual hospitals and workers can remain responsive to the lowest levels, even in these large organizations? Now, as I think I mentioned at the beginning, Catholic social teaching doesn't offer solution, but these guiding principles. Catholics, it can't be used by a party to say, look, the Catholic Church agrees with me, because really what it's offering is these broader principles that you need to pay attention to. But we should always pay attention to them. So the compendium says, the church doesn't attempt to structure or organize society. You need the prudence, you need people who know social science, you need people who know political science to do these things. But what it does is it appeals to, guides, and forms consciences. Okay, so what have I talked about today? All right, so I hope I've convinced you that the Catholic social vision is theological and anthropological. It's based in the understanding of the human as made in the image of God, as possessing dignity, as made for community, as having stewardship over the world, and as possessing reason and free will. Emerging from this anthropology, there are principles that guide social policy. There are rights and duties that we owe to others. There's preferential option for the poor to care for others, the dignity of all. There's the common good. We have to pay attention to the dignity of work. And there's also principles for organizing society, like subsidiarity. So what does this mean for healthcare? Well, we can think of a couple of, I hope I've introduced you to some of the principles that this means, that some of the conclusions that we should get from this, that we should work that all have access to healthcare in some way. We need to pay special attention to the marginalized as we do so and implement programs. We need to address the social determinants of health, these structures of sin which can entrap people. We need to respect the dignity of workers and also implement programs to protect the environment. Thank you very much, and I look forward to your questions. Let's see. Let's stop share. There we go.
So at this point, Paul, nobody has yet typed any questions. Oh, there's one. Could you repeat the anesthetic that is less harmful to the environment?
It is desflurane, which is less harmful to the environment than, oh no, sorry, reverse. Sevoflurane is less harmful for the environment. Desflurane is the one which has the longer half-life in the atmosphere. Sevoflurane.
I've got a question, Paul, if it doesn't seem like anyone. Oh, here's another question from Eula Simeon, who's one of our deacon candidates. What was Pope Francis's recent pronouncement mentioned? You must have mentioned one of his recent pronouncements.
I mentioned a couple of things. I said about Fratelli Tutti, which is his most recent social encyclical. Right, and that develops a lot of the themes I talked about today. Especially it's more focused on immigration, which is another big issue that I just touched on the preferential option for the poor, on these issues of nationalism, things like that. So more of these broader kind of political issues. And on the question of solidarity, which relates to how we are serving the common good, how we are directed towards the preferential option for the poor. I also mentioned his Urbi et Orbi message, where he called for vaccines to be given to all.
So my question for you, Paul, at the beginning of your lecture, you mentioned about the need for social ethics and bioethics. And this is something I experience in teaching both CST and bioethics here at FranU.
Mm-hmm.
Is that lots of things go wrong when you have just one or the other. So I'd like to hear you speak to that a bit. What can go wrong with bioethics without social ethics? And what do you think could go wrong with social ethics without bioethics?
Well, I think you need these because they're complementary, right? I mean, if you are this is what a lot of people treating infectious disease, people doing caring for even a lot of non-communicable diseases. They can do a lot. They can prescribe things in the clinic, but they don't even know whether people can get to the clinic, right, or not, whether they have transport to come to their appointment, whether they can afford the medications that they need. So a lot of the stuff in the clinic can just go out the window and just be useless if you're not also paying attention to these broader social ethical issues. I think that there's also these questions of why are we actually decreasing? Why is our life expectancy actually decreasing now? It's because of these diseases of despair, because of addiction, because of alcoholism, because of all of these things which are taking the life of so many people, working class people in middle age. And these, if you're caring about health and life, you have to pay attention to the broader social issues that are giving rise to it. Now, what's the problem if you're just social issues without paying attention to life issues? I mean, I think, they're totally interrelated. And if you're not looking at the dignity of every individual and their lives, you're missing the point. You're really going to miss major parts of how social ethics should reach. And also, there's a lot that you have to do in the clinic that isn't really tied to healthcare ethics. I mean, when you reach end of life, some things are tied to social factors, but a lot of things are the common experience of death that we're all facing, the common fear, the common difficulty of deciding on life extending treatments, things like that. So you need those also in there just to function well in the clinic.
Thanks. So we've got a few more questions coming in. You could address probably the last one relatively quickly because it's going right now. Someone would like to hear your opinion, Grace, on the recent on the COVID vaccines.
Yeah, so I think the bishops in the Vatican have come out with a very reasonable standard that that follows what the church has been teaching on this back to since to 2005, stated by the Congregation for the Doctrine of the Faith in 2008. So there's been a lot of vaccines have been made using these unfortunate cell lines that were derived from aborted fetuses. But these cell lines, the rubella vaccines, things like that. But these cell lines were actually derived, and the abortions occurred back in the 1970s and 1980s, and it's not an ongoing problem. So what the church has said is we should, as much as possible, hope and call for vaccines that don't require these cell lines, right? And all Catholic organizations have been doing this, but because given the principle of cooperation, we're so distant in time from that. We're so distant causally from that abortion or from taking the tissue from that fetus that, and the dangers are so great from the pandemic that it is reasonable and morally licit, and people in good conscience can receive the COVID vaccines.
Here's another question from Grace. Where would you like to see quality metrics go in the future? She sees the benefit of them. However, in her short time in private practice, she's also seen physicians pressured to fudge numbers in order to meet quality metrics.
Yes. I mean, and the other thing is, I mean, as private practice, the amount of accounting that you have to do and to actually keep this up, and the investment in accounting factors. I think quality metrics, yeah, I mean, you're always, if you're going to judge people by numbers, you are going to get fudging. You're going to get people changing their practice to meet numbers when they aren't necessarily going to, when it's not actually going to benefit the patient. I have a colleague who wrote this great book, Tyranny of Metrics, The Tyranny of Metrics. And what he says is that metrics can be good. It can help us to keep track of how we're doing as professionals. But when you're dealing with professionals, they work best when they're used to inform the group, the professional group, of what's going on. That, oh, you aren't controlling people's diabetes, right? Like other groups are doing. You're really below standard on this. So I would like them to be used more as a support to help professionals reflect on their work and change how they're doing their practice, rather than a kind of mechanism of control, which can have a lot of bad consequences.
Here's another question related to misuses of data and metrics. Damon Boyer, who's a professor of philosophy here, wonders, what about a systematic level? You touched on the misuse of data and the kind of problems it can have by not having a supporting level for individual patients. What about more systemically?
On data, well, I'm going to be talking about this a little bit tomorrow, but I mean, data, you have to make sure your data is good. A lot of the data that is fed into these machines is not good. A lot of this data is already kind of infected with biases that exist from the past. So it can rapidly expand and intensify biases. So a classic example is Amazon tried to figure out an algorithm that could sort resumes so it could more quickly figure out who to hire for programmers. It found that the algorithm never hired women, right? It never approved the women to go through to the next level of the job interview process. Why was that? Well, the way they came up with the algorithm is they set this computer at work on all the people that they hired and to predict who would be the most likely person to be hired by Amazon. And since Amazon was systematically biased against hiring women in the past, that biases was baked into the algorithm, but just made especially powerful and expanded to an especially powerful level. And we see this in, I'll have an example about how this works out in race in healthcare systems as well, and population health systems tomorrow. But yeah, I mean, there are these ways that I could speak of some other ways depending on what exactly you wanted to know about that. But data can have major problems and when introduced naively.
Here's a couple of application questions. Could you touch on the role of Catholic institutions, not hospitals, to provide affordable healthcare to its employees? Do you know of any institutions or dioceses excelling in this area?
Do I know of any diocese? I do not know of, yes, the details of what diocesan healthcare plans include. I think it would say, I mean, it's complicated what exactly the employee is doing and things, but yeah, I think as a basic duty, church institutions, where they're available, has a requirement to provide some kind of health care for full-time employees or employees who work there a significant portion of time.
Would you say this healthcare has to be of a certain level or affordability or something like that, according to CST, in your judgment?
Yes. I mean, it would have to be of a level that would allow people to protection against common ailments, covering pregnancy, covering the things that would need to be covered for a family to live. I mean, it really ties into the living wage issue. Healthcare debt is one of the chief. Healthcare is one of the chief sources of debt and bankruptcy in our society. People who just get overrun with bills and therefore they have to declare bankruptcy from medical procedures. So it needs to be something that will protect people from those dangers.
Yeah, final question, also an application, kind of more broadly. Mark wonders, since there's so much to do, how do we decide on what do we do? What do we work on first?
Yes, that is the difficult question because it is left to where you are in society and what actually do you see around you and what can you do, right? I mean, depends on whether you're at the top of a healthcare system, what you see in or whether you're a doctor on the floor or a nurse on the floor, right? You'll have different kinds of things that you can do and different abilities to do things. There are also different questions that you'll be drawn to, different questions that you will be presented to you. And this is where discernment, prayer, keeping an eye out to read the signs of the time and to see what God's will is calling you to do in your life is very important, right? I mean, this is not something that you could answer on a general level, nor something that Catholic social teaching tries to answer on a general level. It lays out these ground rules, but then calls the faithful to apply them as they can in their lives and workplaces and society.
Yeah, Mark, I've found, at least personally, and in people I've talked to, that even reading regularly Catholic social thought and reflecting on your position more deeply, things will just sort of arise once you begin to think with the kind of mind of Catholic social thought. You'll start to see things and think, oh, I could do something about that. There's also a kind of humility we need to have that that we're working on this together as part of an organized body, and not one of us can do everything. And that's like crazy. You'll kill yourself. That we each need to contribute our part and to trust the rest of the body to also contribute their parts. So do one thing, do it well. I mean, if you think of the kind of impact that someone like Mother Teresa or Dorothy Day had, it wasn't because they did everything. It's because they did their one thing and they did it really well.
That's right. No, I think that's exactly right.
So Sister Martha has thanked you for your important insight. She's part of our sponsoring religious order who owns the health system.
Well, thank you very much. Thank you for having me. And thank you for coming, all of you. I've really enjoyed giving this and answering questions.
Yeah, so I think I'll end it here since the questions have ended, and hopefully I'll see you all in the morning for Dr. Scherz's next lecture. And have a good night.
Okay. Thank you.